Welcome to the deep dive. We take complex topics, look at the sources, and really try to pull out the insights you need. Today we're diving into something pretty serious, a critical medical condition, acute respiratory distress syndrome. You'll often hear it called ARDS. So our plan here is to really unpack ARDS. What is it? What kicks it off? How does it mess with the body? And crucially, how is it treated? We also want to touch on the human side of patient care, especially with the shadow of COVID-19 looming large. We've got a solid clinical guide here to help us navigate. Okay, let's get into it.
Right. So first off, ARDS isn't just like one single thing. It's more of a spectrum. You've got milder forms, sometimes called acute lung injury, initially ranging all the way up to severe life-threatening ARDS. But the core issue, the clinical syndrome, it's this really severe inflammation. It causes widespread damage to the tiny air sacs in the lungs. That's the diffuse alveolar damage. And this leads to, well, sudden and worsening fluid buildup in the lungs, pulmonary edema. You see it on chest x-rays as these kind of cloudy patches spreading across both lungs. And the big hallmark is hypoxemia, dangerously low oxygen in the blood that just doesn't get better with extra oxygen. Doesn't matter how much pressure, like PEEP, you use to keep the airways open.
Okay, so it's not a heart failure thing. It's specific to the lungs.
Exactly. That's a key distinction. It's not driven by elevated pressure from the heart side.
Yeah.
And another really key characteristic, patients often develop what we call reduced lung compliance. Their lungs get stiff.
Stiff lungs, meaning
Yeah.
harder to breathe.
Yeah, much harder. They don't expand and contract easily. Makes breathing really difficult, and it makes it hard for a ventilator to do the work too.
And the impact sounds devastating. The numbers you mentioned earlier.
Yeah, they are sobering. Mortality rates are somewhere between 27% and unfortunately up to 50%.
Wow.
And it's tough because even if someone survives the initial ARDS crisis, they might still face serious complications later, like hospital-acquired pneumonia or sepsis, which can sadly still be fatal. It's a long fight.
It really sounds like it. So given how severe this is, what actually sets it off? What are the triggers?
Well, there's actually a pretty wide range of things that can trigger ARDS. We usually group them into two buckets.
What?
Things that directly injure the lungs and things that cause an indirect hit, like from a problem elsewhere in the body.
Okay, direct injury first.
Sure. Direct injury could be something like aspiration, maybe inhaling stomach contents or near drowning certain chemicals, or breathing in high concentrations of oxygen for too long, smoke inhalation, corrosive stuff, even a direct blow to the chest causing a pulmonary contusion, like a bruise on the lung.
Okay, makes sense. And the indirect insults.
Those are often linked to severe illness affecting the whole body. Think about things like severe COVID-19 pneumonia. That's a big one recently. Also, drug overdoses, fat or air embolisms getting into the bloodstream, serious blood disorders like DIC, or needing massive blood transfusions, even major surgery, problems like pancreatitis or kidney failure, widespread infections. Sepsis is a huge trigger shock from any cause, really,
Right.
and major trauma like multiple fractures or a head injury.
That is a massive list. It feels like almost any major bodily insult could potentially lead to this. And you mentioned our source points out something quite current, this alert about vaping-related lung injury. AVLI.
Yes, exactly. The Quality and Safety Nursing Alert on Evil Eye. It's e-cigarette or vaping product use-associated lung injury. And the CDC noted cases in most states. So it's definitely on the radar as a direct lung irritant that can trigger this.
Okay, so once one of these triggers happens, what's the chain reaction inside the lungs? This is where it gets really complex, right?
Absolutely. It's a cascade.
Yeah.
Those inflammatory triggers basically unleash a storm of cellular and chemical mediators. Think of them as emergency signals gone haywire. These mediators directly injure that super thin barrier between the air sacs and the blood vessels, the alveolar capillary membrane. That's where gas exchange happens. And this damage leads to a severe mismatch between ventilation, air getting in, and perfusion, blood flow. It's called VQ mismatch. Like you might have air but no blood flow to pick up oxygen, or blood flow but no air getting to that area.
So the system breaks down.
Completely. The air sacs, the alveoli, they can actually collapse. This happens because of all the inflammatory fluid, maybe some blood leaking in, and a breakdown of surfactant.
Surfactant, that's the stuff that keeps them open.
Exactly. It reduces surface tension.
Oh.
When it's dysfunctional, the alveoli just collapse like wet paper bags. And the small airways also get narrowed by fluid leaking into the tissue around them. And general obstruction. And all of this leads back to what we mentioned earlier, that decreased lung compliance.
The stiff lungs.
The stiff lungs, yes. And a reduced functional residual capacity, that's the amount of air left after you breathe out normally, that shrinks dramatically. So gas exchange is severely impaired, causing that profound hypoxemia. And you get this phenomenon called shunting.
Shunting?
Yeah, basically blood flows through parts of the lung that aren't getting any air, that aren't ventilated. So it goes back to the body without picking up oxygen.
Which explains why just giving more oxygen doesn't fix it.
Precisely. It results in severe refractory hypoxemia. The oxygen just can't get to the blood effectively.
Wow. Okay, so with this happening so fast, how do clinicians actually diagnose ARDS? What are they looking for?
Well, the first signs often look a lot like severe pulmonary edema, like fluid overload from heart failure. But the key is the rapid onset of severe shortness of breath dyspnea. Usually happens less than 72 hours after whatever triggered it.
And the big clue is the oxygen level.
That's the most characteristic sign, yes. Arterial hypoxemia, low oxygen in the blood that stubbornly refuses to improve, even when you give supplemental oxygen. And we actually classify ARDS severity based on how bad that oxygenation problem is. We use a ratio, AO2 ratio, basically, how much oxygen is in the blood compared to how much is being delivered. That tells us if it's mild, moderate, or severe.
And imaging, the chest x-ray.
Right. Chest x-rays typically show those bilateral infiltrates, that haziness in both lungs, similar to cardiogenic pulmonary edema, but they tend to recede very quickly in ARDS. In some unfortunate cases, particularly if it persists, it can progress to scarring in the lungs, fibrosing alveolitis, leading to chronic severe hypoxemia.
What about listening to the lungs or other tests?
On physical exam, you might see signs of difficult breathing, like the skin pulling in between the ribs, intercostal retractions. And you might hear crackles when listening to the lungs, which is the sound of fluid in those air spaces. Diagnostic tests are crucial too. BNP levels, that's brain natriuretic peptide, can be really helpful. It's a hormone the heart releases when stressed, so if it's low, it points away from heart failure and towards ARDS.
And if that's not clear?
Then maybe an echocardiogram, an ultrasound of the heart, or even sometimes pulmonary artery catheterization to get direct pressure readings, though that's less common now. And on the positive side, signs of recovery include the hypoxemia gradually getting better, the x-ray starting to clear up, and the lungs becoming less stiff, more compliant.
Okay, diagnosis sounds complex, but crucial. Let's move to treatment. How do you manage something this severe? What's the approach?
It's really a two-pronged attack. First, you absolutely have to identify and treat whatever underlying condition triggered the ARDS.
Yeah.
Sepsis, pneumonia, trauma. You have to manage that aggressively.
Makes sense. And the second prong?
Intensive supportive care. That's the cornerstone. Almost all patients will need endotracheal intubation, a breathing tube, and mechanical ventilation. Plus, you need really careful management of circulation, making sure fluid levels are right, not too much, not too little, and providing nutritional support is vital too.
So the ventilator is key. How does that work?
Well, initially you might try supplemental oxygen. But as the hypoxemia worsens, intubation and mechanical ventilation become necessary. The settings on the ventilator are tailored very carefully to the patient. We monitor things constantly, arterial blood gases, pulse oximetry, bedside lung function tests to make sure the settings are right and adjust them as needed.
And you mentioned PEEP earlier. That's part of the ventilation strategy.
It's absolutely critical in ARDS. PEEP, positive end expiratory pressure. It applies a bit of constant pressure at the end of each breath out. This usually helps improve oxygenation quite a bit. It increases that functional residual capacity we talked about, and crucially, it helps reverse alveolar collapse. It essentially props those little air sacs open.
Ah, so it directly counteracts one of the main problems.
Exactly. It improves gas exchange and often lets us use a lower concentration of oxygen, FiO2, which is good because too much oxygen can also be harmful. The goal is always to get the PO2 above 60 millimole Hg or oxygen saturation over 90% using the lowest possible FiO2.
Are there risks with these treatments, with PEEP, for instance?
Yes, definitely. High levels of PEEP can sometimes cause systemic hypotension, low blood pressure. This can happen for a couple of reasons. One is hypovolemia, because fluid can leak out of the blood vessels into the tissues. Another is that the high pressure in the chest can actually reduce the amount of blood returning to the heart, depressing cardiac output.
So it's a balancing act.
A very delicate one. You have to treat the low blood pressure carefully, often with IV fluids, but without causing fluid overload, which would make the lungs worse. Sometimes medications called inotropes or vasopressors are needed to support blood pressure.
What about other supportive things? You mentioned prone positioning.
Yes, that's become a really important strategy, especially boosted by experiences during COVID. Turning the patient onto their stomach, prone positioning, can significantly improve oxygenation in many ARDS patients. Other things include sedation, sometimes temporary paralysis, and as we said, nutritional support is absolutely key.
Okay, sedation and paralysis. We'll come back to that. Are there specific drugs that treat ARDS itself, like a targeted medication?
That's a really important point. Currently, there's no specific pharmacologic therapy that directly reverses ARDS. The treatment is all about fixing the underlying cause and that intensive supportive care. Now, medications are used, but they're supportive. Neuromuscular blocking agents, the paralytics, along with sedatives and pain relievers, are often essential. They help the patient synchronize better with the ventilator, especially if they're fighting it, and they can help reduce oxygen demand, which eases the strain.
I see. What about things like nitric oxide? I thought that was used.
Yeah, inhaled nitric oxide was explored. The idea was it could help reduce that VQ mismatch by selectively dilating blood vessels in well-ventilated lung areas, improving oxygenation. But large clinical trials haven't actually shown it improves mortality rates. So it's not routinely recommended, though may be considered in very severe refractory cases.
Okay. And nutrition, you stressed that. Why is it so critical?
Because these patients are incredibly stressed metabolically.
Hmm.
They're in a highly catabolic state, meaning their body is breaking down muscle and tissue very rapidly to try and cope. They need a lot of calories, like 35 to 45 kilocalories per kilogram per day, to fuel the body and support healing. Enteral feeding through a tube into the gut is always the first choice if possible.
And if not?
Then a parenteral nutrition, IV feeding, might be necessary.
Mm.
But getting nutrition in is non-negotiable for recovery.
This sounds like some of the most intensive care imaginable. Let's shift focus a bit now to the human side of this.
Mhm.
Caring for someone this critically ill, often unable to communicate, that must be incredibly demanding and require deep compassion.
It absolutely is. You're dealing with someone who is critically ill, often terrified, and completely dependent. The nursing care is constant, vigilant. It involves managing all the respiratory stuff, oxygen, nebulizers, chest physiotherapy, the breathing tube, the ventilator, suctioning, sometimes helping with bronchoscopies, and just constant, meticulous assessment. Are the treatments working? Are there complications brewing?
And positioning is a big part of that nursing care, too.
Huge. Nurses turn patients frequently, usually every couple of hours. This isn't just for skin care. It's crucial for improving ventilation and perfusion in different lung areas and helping drain secretions. You have to monitor their oxygen levels really closely during turns because some positions work better than others. And as we mentioned, that prone position lying on the stomach can sometimes make a dramatic difference, particularly in COVID-related ARDS. This is physically demanding for staff, but often worth it.
And the patient's mental state. You mentioned anxiety.
Profound anxiety, often agitation. It stems directly from that feeling of severe breathlessness, the hypoxemia. It's a primal fear response.
Hmm.
And managing that anxiety is critical because being anxious uses up more oxygen, increases the work of breathing, and prevents rest, all things the patient absolutely cannot afford when their lungs are failing.
I can only imagine how frightening that must be, especially being on a ventilator with PEEP. That must feel very unnatural.
It does. PEEP creates this constant pressure. It feels strange. It can definitely cause anxiety and lead to that patient ventilator dysynchrony we talked about, where the patient's breathing efforts are out of sync with the machine. They might try to breathe against it.
So nurses have to be detectives, too, figuring out why the patient is struggling.
Exactly. Is the tube kinked, blocked with secretions?
Yeah.
Is there another problem, like a collapsed lung, pneumothorax? Are they in pain? Is the ventilator malfunctioning? Or is it purely anxiety and the sensation of the machine? Careful assessment is key.
Which often leads to sedation.
Yes, very often. Sedation is crucial to decrease the patient's oxygen consumption, let the ventilator do its job without resistance, and ease that anxiety. There are several common agents used, like lorazepam, midazolam, propofol, dexmedetomidine. The choice depends on the situation.
And if sedation isn't enough, that's when the paralytics come in.
Correct. If, despite sedation, the patient is still fighting the ventilator, or if very high levels of PEEP are needed and they can't tolerate it, then neuromuscular blocking agents, paralytics, might be used. Drugs like pancuronium, vecuronium, entrecurium, they temporarily paralyze all skeletal muscles, including the diaphragm and chest muscles used for breathing. This allows the ventilator to take complete control, ensuring optimal oxygenation and ventilation without resistance.
Okay, this is the part that always sounds so intense. The patient looks unconscious, can't move, can't breathe on their own. But you're saying they can still be aware.
This is the absolutely critical and often misunderstood part. Yes. While they lose all motor function, can't move, can't breathe, can't even blink, they retain sensation and can be fully awake and able to hear.
That's terrifying to think
It
about.
is, which is why communication is paramount. The nurse must reassure the patient frequently, explain that the paralysis is temporary, that they are safe, that the ventilator is breathing for them, and this is non-negotiable. Neuromuscular blockade must never be used without adequate sedation and analgesia, pain control. The goal is for the patient to be unaware and comfortable, not trapped and terrified.
How do you even know how much paralytic is enough?
There's a specific way to monitor it using peripheral nerve stimulation. It's often called the train of 4 test. Basically, a small device sends 4 tiny electrical impulses to a nerve, usually in the wrist or near the eye, and you watch for muscle twitches in response. The number and strength of the twitches tell you the degree of blockade.
So you can fine-tune the dose.
Exactly. No twitches means 100% blockade. 4 twitches means little to no blockade. You aim for a specific level, usually 1 or 2 twitches, to ensure adequate relaxation for the ventilator without complete paralysis if possible.
But using these drugs must come with significant risks too.
Oh, absolutely. Constant vigilance is required. The biggest immediate risk is accidental disconnection from the ventilator. If that happens, the patient cannot breathe at all. So all alarms must be on and functioning, and someone needs to be right there. Eye care is vital because they can't blink, which can lead to dry eyes and corneal abrasions. They're at high risk for blood clots, VTE, because of immobility, muscle atrophy, foot drop from nerve pressure, stress, ulcers in the stomach. The list is long, and skin breakdown is a major concern.
It really highlights that nursing alert in our source assessment is everything because the patient can't tell you if something hurts or feels wrong,
Yeah.
and the absolute need for concurrent pain relief.
Precisely. Analgesia must be given alongside paralytics. And other care continues frequent oral care, suctioning, repositioning, even though the patient appears unresponsive.
And talking to them, not about them.
Critically important, assume they can hear everything. Explain procedures. Offer reassurance. And it's just as important to explain this to the family. Seeing a loved one suddenly paralyzed, it can be incredibly distressing if they don't understand why it's being done and that it's temporary and requires sedation.
This whole discussion underscores the intensity. Now, we have to talk about COVID-19. Ards became almost synonymous with severe COVID for a while there. How did the pandemic change the ARDS landscape?
It changed everything, really. ARDS was, tragically, the most serious complication and the most common cause of death for hospitalized COVID-19 patients, especially early on. Data from China early in the pandemic was stark. About a quarter of hospitalized patients needed ICU care, mostly for respiratory failure and ARDS. And the mortality rate for those ARDS complications was incredibly high, over 50% in some reports.
Did COVID-related ARDs look different from typical ARDs?
There seemed to be some key differences, yes. Pathologically, while the air sac lining cells were damaged, there often wasn't as much damage to the cells lining the tiny blood vessels in the lungs. This maybe resulted in less of that really exudative, fluid-filled picture sometimes. Clinically, one really challenging aspect was silent hypoxemia. Some patients had severely low oxygen levels but didn't feel short of breath, which could lead to sudden, rapid deterioration.
That sounds incredibly dangerous.
It was. And another surprise, some mechanically ventilated COVID ARDS patients actually had relatively good lung compliance. Their lungs weren't as stiff as expected in classic ARDS, at least initially. The timing was also different. Typical ARDS usually hits within about 72 hours of the insult. With COVID, the median time from symptom onset to developing ARDS was longer, often around 8 to 12 days.
But the basic classification and management were similar.
Broadly, yes. The mild, moderate, severe classification based on the PO2-A5O2 ratio was still used, and many of the core supportive strategies remained the same: ventilation, PEEP, fluid management, nutrition.
Were there specific treatment recommendations that emerged for COVID ARDS?
There were. Based on accumulating evidence, specific guidelines evolved. Low tidal volumes on the ventilator, smaller breaths, were strongly recommended to minimize ventilator-induced lung injury. PEEP was definitely used, generally above 5 centimeter H2O, but with caution and close monitoring for barotrauma if levels went above 10. Low-dose corticosteroids, like dexamethasone, were found to be beneficial, likely by reducing inflammation, so they might be prescribed.
What about nitric oxide or paralysis?
Nitric oxide was generally not recommended routinely, similar to non-COVID ARDS, though potentially as a rescue therapy. For prone positioning, it was strongly recommended for moderate or severe cases, often for long durations like 12 to 16 hours a day. And for neuromuscular blockers, the preference shifted towards using intermittent boluses rather than continuous infusions, unless the patient was persistently fighting the ventilator.
And the human challenges. COVID must have amplified those immensely.
Hugely. Isolation was the defining factor. Patients were often more likely to experience neurologic issues like delirium, sometimes needing higher sedative doses. But the biggest difference was the lack of family. Visitors were typically barred to prevent spread, so patients faced this terrifying illness utterly alone, except for staff covered in PPE.
That must have been incredibly isolating for patients.
And for the staff, too. Nurses had to minimize time in the room, practice strict precautions. It potentially made patients feel even more isolated and agitated during a time they needed human connection the most.
So, pulling all this together, what does this deep dive really tell us? It just paints such a vivid picture of ARDS, doesn't it? The sheer complexity, whether it's the classic form or complicated by something like COVID-19, it's this incredible high-stakes balancing act between really aggressive medical technology and deeply compassionate human care. Understanding ARDS really goes beyond just the lung mechanics. It's about the body's limits, its resilience, and the immense dedication required to care for someone at their most vulnerable.
It absolutely does, and it really forces us to think about that experience for the patient critically ill, often unable to speak or move, yet potentially aware. It highlights how vital it is for us as clinicians to navigate not just the physiology, but that complex psychological space. And it leaves me wondering, looking forward, how can technology maybe help bridge that communication gap for patients who are awake but paralyzed? What tools might give them back some agency, some voice in those extreme moments? And maybe more philosophically, what does facing these challenges teach us about the core of human connection, about empathy, when communication is stripped down to its most basic or even nonverbal level?
That's a powerful question to reflect on. Thank you for joining us for this deep dive into ARDS.